So pretty much the OASIS tool is really the sole responsibility of one clinician. It can be a PT, it can be a speech therapist, or an RN. Those are the three people who can fill out an initial OASIS assessment. Now, OT can come into the picture and continue a patient, but they can't start a patient.
Okay.
That's a Medicare rule.
Okay.
So when they do that assessment, they're responsible for really looking at the patient as they are at that snapshot moment in time when they open the patient and really, saying, are they short of breath, are they not, are they in pain, are they not, and to what degree of pain. And then every problem that's identified at admission, we have to have an intervention for, and we have to address it, and we have to try to make it better, along with where the patient wants to go. So pretty much we try to return the patient to their prior level of function.
Okay.
And then my job is to get that document in my hand and make sure that it matches. It's a lot of questions. And so I got to make sure that if they're short of breath on page 3, they're still short of breath on page 4, and then everything makes sense for the patient. So that's my role in it.
Okay. Let's see. How do you determine what's necessary for like a pre-admission care planning?
Pre-admission care planning, it's a little different, in the hospital setting than it would be here in home care, because pretty much all we get pre-admission is an order from the doctor to say, we saw this patient and they have a UTI and you need to go out there and teach on their antibiotic. And then we get a med sheet from the doctor's office, a history and physical most of the time, and usually since it's visiting physicians, they've seen the patient in the home, we get the record of their visit. So what we do before going out to the patient's home, we review all that paperwork that we receive in the referral packet from the doctor. We contact the patient and or family member, power of attorney, whoever we need to get a hold of to set up the admission. And sometimes prior to going out, there's questions, the family has, like, why do I need this, or what's happening, what does the doctor think? And we always have to work under doctor's orders, so we always have to say, this is something that your doctor referred you to us for this particular reason. Here's what we do. We come out, assess, we educate, we make sure you're not having adverse reactions to your medications, we make sure your infection is going to be resolved or your wound is going to be healed or whatever's going on with that patient. So that's kind of our pre-admission, is just that prior contact with the patient or family.
Okay. And then say a person needs more care than that is initially planned, how do you determine like payments and work with insurance companies?
We take certain kinds of insurance. We take all Medicare, some Medicaid, and then certain insurance plans. What we do when we receive a referral is it goes to our central intake department, and they determine whether we're a participating provider with that insurance plan. If we're not, then that referral will go to a home care agency that is. So pretty much once we get the referral, the insurance stuff is all taken care of.
Okay.
Yeah, and then we are responsible to let the patient know if they have any co-payments for the home visits, or what their percentage of payment is. And normally, the majority of our patients are Medicare, and it's 100% covered.
Okay.
So, and we let them know that up front, because that's usually a concern. How much is this going to cost me? Yeah.
And then let's see. How do you work around sudden issues such as a hospital-acquired infection received for planning care and providing services? So say one of the patients ends up in a hospital, do you work with that hospital to know what is going on, or is it all strictly through BPA?
No, it's definitely communication with the community hospitals too. When we admit a patient, we do full body assessment, making sure that there are no wounds or things that we're going to find 2 weeks down the road because we didn't look in the beginning. So we always do that full body assessment, much like they do in a skilled nursing facility or when you go into a hospital. And so we can identify every problem that's there at the date of admission. If a patient develops decubitus ulcer, pressure ulcer, after we've had them, then we have to take responsibility for that, basically. Just like the hospitals have to do now. If they develop a decubitus in the hospital, Medicare is not reimbursing hospitals for the care of that wound. So that's why it's so important that up front you know what's going on with your patient. So we really drive down those assessment skills right at the beginning. If we have a patient, which we do, well, one of our initiatives in home care is to keep people home. That's what we want to do. And we actually get judged on our outcomes. And one of the outcomes we get judged on is rehospitalizations. So of course when we open a patient, if they're pretty sick, if they've got like an exacerbation of COPD or pneumonia or really fluctuating blood sugars, then we try to get out there like frequently, up what we call it is front loading the visits. So we're there 3 or 4 times a week to start to try to get them under control, because we don't want them to have to go back into the hospital with an infection or, bad blood sugar or hyperglycemia. So we really try to keep them home. But that doesn't always work.
No.
And we obviously do have patients that go back in. When one of our patients goes into the hospital, we're responsible to notify Medicare by making an OASIS, filling out a transfer OASIS document. That document tells Medicare our patient went into the hospital and here's why. With that said too, we're then responsible to find out what facility they went to, notify that facility that this is our patient, fax them any information that they need on the patient, med list, most recent med list, most recent visit notes, so that they have that information for continuity of care. And then once we make contact with the hospital and that discharge planner who's assigned to the patient when they're in there, then that discharge planner, when the patient's ready to be discharged, sends us their continuity of care upon discharge. And then we're required by Medicare, CMS, to go back out within 48 hours of that hospital discharge to create another OASIS document called the resumption of care. And then that again tells Medicare why they were in the hospital, what happened to them while they were in the hospital, what kind of procedures did they have, what were their inpatient diagnoses, and then now what's our main focus for home care. So it tells the story of the patient from home to the hospital to the nursing home, back to home. So it's, again, that whole continuum of care.
Well, thank you very much.
Thank you very much.
I have a quick question.
Yeah.
More on the financial side. Do you guys, as Jess was telling me, that you guys have multiple facilities here within this center. What about integration as far as the financial concerns? Do you guys have integrated services together? Vertical integration, has that helped you guys out a lot, or?
I would probably have to defer that question to my administrator, because the way it works for us is I'm the clinical manager, so I manage the clinical team and all of the what needs to be done for the Medicare conditions of participation and the documentation that we do, and how we treat our patients and the quality care we provide. But he, as the administrator, runs like the financial side of the business. So while I know that our OASIS questions and the way we answer things honestly about the patient's condition, it all ties into what Medicare reimburses us for. Like if our patients have wounds, they're going to give us a little more money because we have to provide them wound care supplies. So it's all, the clinical aspect does feed into the financial aspect of what we're going to get back. But as far as like VPA and Grace and Pinnacle, how they work together, I would have to have you ask our administrator.
Were you here when they integrated, or have you been?
No, I've been here since April.
Okay.
And it's my understanding that this agency actually opened in 2009.
Okay.
It's a newer agency. Because BPA was first, and then you guys, and then I think Grace was right after you.
You haven't heard from anybody that was here at that point how smoothly it went, maybe, or? Unfortunately,
I don't think anybody's here now that was here then.
Okay.
So yeah, it's kind of before my time, and even the administrator's been here, he's been here a year now, which is the longest standing administrator that they've had for this agency, so.
Okay.
Yeah, it's probably.
All right.
All right, thanks.
Thank you.